Chapter 10 of ICD-10-CM is for diseases of the respiratory system. This presentation will cover the official ICD-10 guidelines specific to this chapter. There will also be clinical scenarios to practice coding what you just learned, followed by a small quiz at the end of the presentation. For each coding example, you will need to pause the webinar and use your ICD-10-CM coding manual to code the scenario. Once you resume the webinar, we will go over the correct codes, the rationale behind them, as well as how to locate them in the ICD-10 manual. Keep in mind that there may be more than one way to find a code. We are aware that there is a great deal of information contained in this presentation. Therefore, at any time during the webinar, please feel free to pause and replay as needed. It is important that you have already completed the Introduction to ICD-10-CM webinar, as you will use the conventions and general guidelines discussed in the introduction to complete the coding scenarios. As you can see on this slide, the codes for this chapter start with the letter J. If you remember from ICD-9, the respiratory codes all started with the numbers 4 and 5. In ICD-10, certain terminology has been updated in this chapter. For example, asthma is now classified as mild intermittent, mild persistent, moderate persistent, and severe persistent. Also, unlike in ICD-9, this chapter now contains a note at the very beginning of the chapter, meaning that it applies to all conditions in the chapter, which states, when a respiratory condition is described as occurring in more than one site and is not specifically indexed, it should be classified to the lower anatomic site. For example, the term tracheobronchitis is classified to bronchitis. Another note that applies to the entire chapter instructs the coder to use an additional code where applicable to identify conditions such as tobacco use. Therefore, any time where documentation contains a respiratory condition, along with mention of either history of smoking or current smoker, the smoking code should be reported with the respiratory condition. This is important for public health tracking. In this chapter, acute exacerbation of COPD and asthma, which are categories J44 and J45, indicates a worsening of a decompensation of the chronic condition. It is not the equivalent to an infection on top of a chronic condition. However, an exacerbation may be triggered by an infection. So, an exacerbation of asthma is not when an asthmatic patient gets an upper respiratory infection. However, an asthma attack would be an example of an acute exacerbation. One of the important changes from ICD-9 to ICD-10 for respiratory conditions is the increased specificity needed for documenting and coding a patient's asthma. The National Asthma Education and Prevention Program has classified asthma as mild intermittent, mild persistent, moderate persistent, and severe persistent, and these terms should be reflected in the documentation so that the most accurate code can be assigned. Documentation should also include any exacerbation or status asthmaticus. Now I'd like to try an asthma example. The assessment plan states pharyngitis, viral, gargle, moderate persistent asthma. Treat with pro-air inhalation, 2 puffs every 4 to 6 hours as needed for wheezing. We actually took this from a real note, and the bold words were what needed to be added to make the documentation ready for ICD-10. So how would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The first code is J02.8, acute pharyngitis due to other specified organisms. To locate this code, start at pharyngitis in the alphabetic index and then locate viral, not elsewhere classified, which points to J02.8, which you would then confirm in the tabular. There is an instructional note in the tabular which states use additional code B95 through B97 to identify infectious agent. Therefore, our next code is B97.89, other viral agents as the cause of diseases classified elsewhere. This indicates that a virus caused the pharyngitis, even though we don't know which virus it was. This code can be located by either following the instructional note at J02.8 or by using the alphabetic index starting at the term infection. From here, you would look for virus and then as cause of disease classified elsewhere, which points to B97.89, which you would then confirm in the tabular. The last code is J45.40, moderate persistent asthma, uncomplicated. To locate this code, start at asthma in the alphabetic index, then find persistent, and then moderate, which points to J45.40, which you would then confirm in the tabular. Remember, even though the patient has an infection superimposed on their asthma, this is not considered an acute exacerbation of asthma. For this encounter, the pharyngitis should be coded first because it is an acute condition. Let's do another example. A child was seen with a high fever, cough, and chest pain. Diagnosis of diffuse bronchopneumonia was made. Gram stain of the sputum showed numerous small gram-negative coccobacilli. Diagnosis: Haemophilus influenza pneumonia. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The answer is J14, pneumonia due to Haemophilus influenza. To locate this code, start at pneumonia in the alphabetic index, then locate Haemophilus influenza with the term broncho in parentheses as a non-essential modifier, which points to J14, which you would then confirm in the tabular. Since the term broncho is a non-essential modifier, meaning it is a supplementary word that may be present in the documentation without affecting code selection, we do not need a separate code for diffuse bronchopneumonia, as broncho is included in the pneumonia code. For the next example, we have a patient with increasing shortness of breath, weakness, and ineffective cough. Treatment included oxygen therapy and advice for cigarette smoking cessation. The diagnosis was listed as acute respiratory insufficiency due to acute exacerbation of COPD and tobacco dependence. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The first code is J44.1, chronic obstructive pulmonary disease with acute exacerbation. Since COPD stands for chronic obstructive pulmonary disease, start by locating disease in the alphabetic index and then locate the term pulmonary. Indented below this is chronic obstructive, then with, and then exacerbation with acute in parentheses, which points to J44.1, which you would then confirm in the tabular. We do not need to code the acute respiratory insufficiency because the underlying cause of the insufficiency is documented. Remember, symptoms are only coded when there is no definitive diagnosis. The second code is F17.210, nicotine dependence, cigarettes, uncomplicated. To locate this code, start at dependence in the alphabetic index, then locate the term drug. Indented below this is nicotine, and then cigarettes, which points to F17.210, which you would then confirm in the tabular. If you don't think to start at the term dependence and looked up smoker, this will direct you to C dependence, drug, nicotine. It is important to code this condition because even though the patient came in for their COPD, smoking has a direct effect on COPD. Also remember that there is a note at the very beginning of the respiratory chapter that applies to all codes in the chapter, stating that any smoking exposure should also be coded. Our final code is Z71.6, tobacco abuse counseling, as counseling was part of this encounter. To locate this code, start at counseling in the alphabetic index and then locate tobacco use, which points to Z71.6, which you would then confirm in the tabular. For the next example, the patient was brought to the ED with severe difficulty in breathing. Diagnoses for this patient: acute respiratory failure, acute bronchitis with acute exacerbation of COPD. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The first code is J96.00, acute respiratory failure unspecified whether with hypoxia or hypercapnia. This condition is coded first as it is the most acute. To locate this code, start at failure in the alphabetic index, then go to respiration/respiratory, then find acute, which points to J96.00, which you would then confirm in the tabular. The next code is J44.0, chronic obstructive pulmonary disease with acute lower respiratory infection. Since COPD stands for chronic obstructive pulmonary disease, you would start at disease in the alphabetic index, then locate the term pulmonary. Indented below this is chronic obstructive, then with, and then acute bronchitis, which points to J44.0, which you would then confirm in the tabular. There is a note which states use additional code to identify the infection, but we don't know what type of infection the patient has. Our final code is J44.1, chronic obstructive pulmonary disease with acute exacerbation. Even though we already have a COPD code, we have not captured the acute exacerbation, which is indented below the term with in COPD in the alphabetic index. When you confirm J44.1, there is an excludes to note for J44.0, meaning that the two conditions are not included in the same code, but that they may both exist together. Therefore, both J44.0 and J44.1 should be coded for this patient. For our last example, the patient was treated for cough, fever, body aches, and headache. Diagnosis: upper respiratory tract infection due to avian flu. How would you code this? Please pause the webinar to complete this example and then hit play to continue and learn the answer. The answer is J09.X2, influenza due to identified novel influenza A virus with other respiratory manifestations. To locate this code, start at influenza in the alphabetic index, then locate avian, which has a note next to it which states, see also influenza due to identified novel influenza A virus. After we follow these directions and our identified novel influenza A virus, the term with is indented below, followed by the phrase upper respiratory symptoms, which points to J09.X2, which you would then confirm in the tabular. Remember, we don't code the symptoms since we have a confirmed diagnosis. Now it's time for our quiz. Our first question is, what is the code for upper respiratory infection? The second question is, what are the code or codes for allergic rhinitis due to cat dander? The final question is true or false. A code from subcategory J09.X is assigned when documentation indicates probable avian influenza. You can pause the webinar to write down your answers and then hit play to find out if you were correct. The answer to our first question is J06.9, acute respiratory infection unspecified. To locate this code, start at infection in the alphabetic index, then go to respiratory, and then upper, which has the term acute in parentheses as a non-essential modifier, which points to J06.9, which you would then confirm in the tabular. The answer to the second question is J30.81, allergic rhinitis due to animal in parentheses cat, dog, hair, and dander. To locate this code, start at allergy, allergic in the alphabetic index, then locate dander, which has the terms animal and rhinitis in parentheses as non-essential modifiers, and this points to J30.81, which you would then confirm in the tabular. Our third answer is false. Subcategory J09.X is for confirmed avian flu, not probable. Remember, for professional and outpatient services, we only code for confirmed conditions. Otherwise, we code the symptoms. Remember, the United States will begin using ICD-10 on October 1st of 2015. After the October 1st compliance date, it will be very important to verify that claims are being received and to check remits for denials based on the ICD-10 conversion. This concludes Chapter 10 of ICD-10-CM, Diseases of the Respiratory System. Please feel free to check out our webinars on all 21 chapters of ICD-10-CM. If you need further assistance with ICD-10 training for physicians and/or staff, please visit the VantagePoint website at www.vantagepointconsult.com or call us at 203-288-6860.